We'll get started. So tēnā koutou katoa, and welcome everyone to the Bioethics Centre seminar. It's a real pleasure to welcome our speaker for today, who's joining us from Wellington, Associate Professor Giles Newton-Howes from the Department of Psychological Medicine. So thank you very much for joining us, Giles. For those who are joining us on Zoom, we just ask that you stay muted during the presentation, and then during the Q&A, you can use the raise hand function for to signal that you'd like to ask a question. And also just to let everyone know that we are recording the session today, including the Q&A. So no mai, haere mai, welcome everyone, and Giles, the floor is yours.
Thank you very much, Elizabeth. And despite what you've just heard, I'm going to try and do things a little bit different, maybe. So I'm going to ask, I can't see you all on screen. I have two screens, but I can't see you all. So can you see my slides, Elizabeth?
Yes, I can. Yep.
Okay,
absolutely.
So two things. One, I'm a massive not fan of speaking to black boxes. So my preference is if everybody online can unblack box themselves, even if you're busy checking your emails while you listen to me, which lots of people do. I can no longer watch a movie with my kids without them texting their mates and doing a million and one other things. And I just think this is the way the human brain is going. So I take no offense if people want to do that. And there's a reason I want you to have your screens on, of which I can only see a few of you. And that's because I guess I'm very aware, one of the things I particularly like in this space is people know very different things. So I am going to encourage you, if as we go, there are things I say, which you think I take as statements of fact, or things I say that make no sense to people, if you interrupt me, and I'm going to have to ask Elizabeth if she could be the person to watch that. You can raise your hand. I don't know how to use the hand function, or raise your virtual hand, or you could do that in the room. And the reason for that is, as we go, if I can explain things to make them clear, I will. I guess I'm going to try and cover a fair bit of ground, and I feel slightly less organized than I normally am when I've done this in the past. And again, I'm going to positively reframe that as an opportunity for greater engagement in a discussion of what we're going to talk about. And so we're going to cover lots of stuff, borderline personality disorder. We're going to talk a little bit about capacity, how these things go together, and what they tell us about all of our capacity assessments in medicine. So that's kind of what I'm hoping to do today. I think this is about half an hour long, and the reason it's half an hour long is I think the discussion's far more interesting than listening to me jabber at you. I always think this is a good place to start. And again, people are coming to this into this area from a wide variety of different backgrounds and interests. So I do a little bit of qualitative research as well as doing a little bit of quantitative research, and what my quantitative research friends describe as polemic, which is this stuff. And so I think it's important to kind of get a grip for that so you can see where I'm kind of coming from. So I'm a Wellingtonian. This is home for me. I love New Zealand and I love New Zealanders. And I guess that's kind of how I was brought up. My first degree is in classical studies. And so I spent a lot of time in that kind of, I guess, the arts world, and did a chemistry degree as well before I went to Otago, where I got my MBCHB from, and then went to England and spent 6 years in England training to become a consultant psychiatrist. So I'm interested in borderline personality disorder as interesting psychiatric disorder, and it interests me both in terms of what's going on in the mind, as well as interesting me in how that reflects in the behaviours that patients with borderline personality disorder have. As you'll discover as we go through, the other thing that interests me about borderline personality disorder is some of the ways it's not a personality disorder like every other personality disorder. I think training in England was a very lucky thing for me, and the reason I think that is because I saw a huge number of cultures and a huge number of different views of the world. For about 2 of my 6 years of training, 1 in 5 interviews on average was done through a translator from people from elsewhere. And I guess what I realized during that was, although I was kind of bound into the white Western model of medicine and bound into the law in England, obviously, things weren't always quite as simple as they seem. So the sorts of ways the law talked about a capacity assessment, for example, didn't necessarily reflect how other people saw capacity. And that sometimes put me in this unusual position as a doctor, trying to figure out what I should be doing and what was legal and what was not legal and what was kind of moral or right. And so I guess this question has sat with me for 15 or 16 years at least, and one I continue to grapple with. And so I guess what that has done is it's led to a bunch of teaching and understanding that I have, which might be clear to some of you, but might not be to others. And I guess this is true too, right? Medicines are weird. My partner is busy assaulting people all day. It may kill people at work today. And that's okay. And people love her for it, and she gets lots of money because she's a surgeon. And if you think about it, that's really strange. I may see someone tonight on call and put them in hospital, even though they don't want to be there, and give them chemicals which will change the way their brain works, even though they don't want them. And somehow not only is that okay, but kind of expected of me from various parts of society. And I think that's weird. It's also true that over time, medicine has done some wacky stuff. And so these are just a few examples of some of the interesting things that we've done in medicine. So for a long time, we really promoted smoking tobacco as a way of treating asthma. We thought leeches were a great way to get rid of illnesses. I mean, actually, using methamphetamine to reduce obesity works really well, but has some pretty bad side effects. But for quite a long time, we did things like lobotomies on patients to treat their mental illness. So I'm mindful of the fact that I do a bunch of stuff that seems kind of weird to me, and wonder how this will look, in a generation's time, will people look back on my profession and wonder about what we do. And I think, at least for me, that provides an even more pressing reason to make sure we've got kind of sound moral and ethical explanations that back up what it is we're doing and why we're doing it. So what I'm going to do is start with a clinical case. Can I just very quickly, how many people in here are medics? Me and Ben, the only two I can see. 3. Oh, hi, so a few. There's a few doctors here, but a lot of not doctors. So this might really be what I need to do tonight at 7 o'clock. I've done this lots and lots and lots. Molly's not a real patient, but Molly is an archetype of a real patient, and the sort of real patient I see a lot of times. So I get called by an ED registrar or SMO. Sometimes I get called by one of my junior registrars. And this is the sort of thing that's happened. So we have a young woman. She's in the emergency department. She carries this diagnosis, borderline personality disorder. She's done something that's life-threatening after what can be a pretty difficult thing to get your head around, and has been really happy to be worked up. And what we see is treatment is needed, but now she refuses it. And people in ED get pretty upset by this. And I think there's lots of sociological reasons for that, but they get pretty worried about the fact that this might lead to Molly's demise, possibly might not be good for them occasionally, and people are worried about what to do. And certainly when they look at this, they, on the one hand, think Molly's perfectly able to say no, but on the other hand, this feels really wrong. And so for some of you who practice medicine, you may reflect in similar situations you've been in where this sort of thing occurs. And this is the problem. So on the one hand, Molly seems to get it. She's had these tests. They show she needs treatment, and they show that without treatment, what her behavior has done is put her in the position where she might die. And for those of you who don't know, if you take enough paracetamol, you end up with something called central lobular necrosis of your liver, which is a really mean way of dying too. It's not nice on any level. But on the other hand, she seems to kind of have all of these understandings, but doesn't want treatment. And so the first thing I'd like to do is just have a quick straw poll on the basis of the information you've provided, and I'll give you 2 minutes to ask me other questions if you have them. Who would strap her to a table and treat her? And treating her means sticking a needle in her arm for 12 hours. Would anyone do that? 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 Would I can't see anyone, Elizabeth. Is anyone I can't see? Would anyone? Is that you, Grant?
Yeah.
Okay. Yeah, there might be people in the room I can't see, but no one on Zoom seems willing to do that.
Grant will do that, but nobody else would. Okay, and so
Well, I'm a surgeon by background.
So
I
what
do
I want-
violence to people all the time.
what I want to make clear is, apart from Grant and maybe me, everybody else in here has just condemned a 28-year-old young woman, Molly, on the basis of an impulsive decision to death. Yep. On the one hand, she gets her life and she gets to carry on for the loss of 12 hours of autonomy potentially. On the other hand, she's dead. That's pretty big, a pretty big call you've made. And of course, Molly's not real, so it's kind of easy to make that call when Molly's imaginary. But this is my real life. So when I see people, this is what I really do. Okay. And so I think it's kind of important to think, is it okay? Is respecting Molly's cross-sectional legal capacity to make a choice worth the consequence that she will die? So that is the question I guess I ask when I think about this. And I think I've thought about this in a lot of different ways. And one of the ways I think that has really challenged me or helped me to think about this is to think about this in the context of this other diagnosis that I come across quite a lot. And that's personality disorder. So I've been interested in personality disorder and personality pathology for a long time. I now work in a regional personality disorder service. Like literally every patient I engage and interact with has a personality disorder. Most people with personality pathology who seek help have borderline personality disorder. So to me, all of this seems second nature. I'm aware that even to some of the other doctors in the room here, personality disorder is not something you see very much. This is a definition of personality disorder that comes from the NHS. It's information for patients. And the reason I quite like it is because it's easy to understand. You don't need 6 years at med school to get your head around what it means to have a personality disorder. It's something about how you feel. It's something about how you see the world. It's something about behaviors that it describes as odd. So at least in some ways, other people see them as odd. Right? And it's pretty distressing to other people, like my ED physician friends, as well as whānau and people themselves. When I think about personality disorder, this is how I tend to describe it to people. It's about having difficulties in understanding yourself, difficulties in understanding relationships or others, and difficulties in understanding your place in the world. And it doesn't just happen at work, and it doesn't just happen, when you're with your mum and dad. It happens everywhere. So happens work and love and play. This is in all parts of your life. So it's something that tends to be global. It's something that affects most parts of your life. And it's really difficult. I mean, it's difficult for the individuals who carry this experience with them on an hour-by-hour and day-by-day basis. And it's difficult for the people who engage and interact with them, like family, like the police, like society, like friends, like doctors in ED. And the sort of personality disorder we see the most, and the personality disorder that most non-psychiatry doctors are familiar with, is this beast called borderline personality disorder. Now, this term originated initially back in 1964 and was written about by a guy called Otto Kernberg, a medical doctor who trained as an analyst, works in New York, and he talked about it as being on the border between neurosis and psychosis. So if you write like vignettes, so a short paragraph that kind of describes a patient, and you do this for all sorts of different psychiatric patients, and you give them to SMOs and say, what's the diagnosis? The diagnosis we all agree on the most is major depressive disorder. The diagnosis we all agree on next most is this thing, borderline personality disorder. So consultant psychiatrists recognize this thing. They see it, they recognize it, and it talks about problems in these 4 domains: affect dysregulation, there's difficulties in understanding how you feel in yourself and wide swings in that. Capacity to manage interpersonal relationships, and this is on a moment-by-moment basis as well as more longitudinally. When people talk about cognitive disturbances, this is about recognizing self, a term people might have heard as mentalization, and that's having an internal mental construct of who you are and having the capacity to develop an external mental construct of who other people are. So it's a way of recognizing people and being able to understand that information in relation to people. And then you get these behavioral disturbances that cause people problems like suicidal or self-harming behaviors. On a side note, it's not clear that Molly was suicidal when she took her packets of paracetamol, and that's often not obvious. Nonetheless, the behavior in and of itself is fairly lethal. So if you look on a general population level, depending on which population you look in, maybe 1 in 100 to 1 in 150 people will have borderline personality disorder if you sit down and formally diagnose it with an instrument. It may be about 0.1% of people have this in a pretty bad way, a way that often needs secondary mental health services to engage them. So although that doesn't seem very common compared to many of the disorders we think about in medicine, it's not that unusual. It's often a disorder of young people, so sort of 16 to 35, and behaviors can be impulsive and very dangerous like Molly's, so it can lead to really serious consequences. And even though we recognize this thing and we can identify the domains of what this thing is, there is really significant debate in the personality disorder academic community. So I spend a lot of time doing research in this area about whether personality disorder is actually a personality disorder. So this is a quote from a paper that's going to come out in Nature pretty soon. And it's written by or two of my mentors, really, Peter Tyra and Roger Mulder. And some of you might know Roger, he works in Christchurch. And they very strongly form the view that although what we see is recognizable and is distressing, and they would both argue constitutes a mental illness, they wouldn't say it constitutes a personality disorder, because at least according to some people, personality disorder is about having something structurally different from all of us. So another way of describing this is that people with personality disorder have the same sorts of difficulties we all have. They just have them in spades, right? They have them in a lot of areas, a lot of the time, as opposed to most of us who have some of them, some of the time in some areas. Okay, and that seems to be a difference only of degree as opposed to a qualitative difference of otherness. So when I think about borderline personality disorder, I'm thinking about people who share similar characteristics to all of us. They just have them in a more significant way. And I think when I think about capacity, the reason that's important is because I think some of what understanding capacity or the consent to intervention, having the capacity to consent, reflects a little bit on what that might mean for all of us when we think about the capacity to consent. And so let's keep Molly in mind. So if we think about what it means to have a borderline personality disorder, it talks to cognitive problems of understanding self. It talks to interpersonal problems of understanding others. It talks to difficulties in seeing where you sit in the world. It talks to impulsivity, and it talks to fear of abandonment. And then you get this behavioral oddness. And so if we think about those and the circumstances under which Molly took her paracetamol, then we have to, I think, ask the question, is she really capacitous? And obviously this is a critical question, and one that's come in front of the courts actually more frequently over the last few years. And so from a legal perspective, we've seen a real right in human rights legislation in a very white Western way. So this is about your individualness and how important it is that we essentially take a negative liberty perspective and respect your individualness, right? And so what taking this view would say is that Molly has the capacity to retain information. She has the capacity to understand it. She can tell us her decision. So the real question is, can she weigh it in the balance? And so this is a phrase which has been used in litigation and is used as one of the foundations for understanding our capacity. This book that's come out really appallingly badly. And if you've got particularly good eyes, you might recognize the last name of one of the three authors who's sitting in here. it has been really nicely, yeah, hey John, has been really nicely articulated in the New Zealand context. So this book is comprehensive. If you look at the Triple PRA, so a piece of a statute, it's comprehensively described there. And if you go to the case law, how it is applied is pretty clear, that all you got to do is tick these 4 boxes and you're good to go. So as a doctor, if I think you tick these 4 boxes, my legal obligation is to allow you to make your own medical choices. I need to support your right to have your choice. And so if I think about Molly, what that suggests to me is that I absolutely should be letting her leave if she doesn't want treatment. She told me doesn't want to, understands these consequences, including the serious consequence of a pretty grim death in a pretty short time frame. But I think when I think about this hard, particularly in the context of someone like Molly with borderline personality disorder, is it raises, for me at least, some of the underlying assumptions that are talked about far less frequently when we think about the capacity assessment. And what they speak to are some of these underlying assessments that for many people most of the time might be true, but I wonder if very few of them are true some of the time, and certainly not in small times of emotional distress for someone like Molly. So the first of those assumptions is that a cross-sectional decision, one that's made now, is reflective of someone's longitudinal views. So the assumption here is that our capacity assessment is made, and people talk about this as being time and decision specific. But of course, that's pretty difficult from a kind of a moral perspective, because what's clear is that Molly is not making decisions for her cross-sectional self. Molly's actually making decisions for her future self in a narrative kind of a way. It's not her current self who will suffer if she chooses to refuse treatment. It's her future self. So I think one of the assumptions here about the capacity to refuse treatment is fundamentally incorrect. And that is that the cross-sectional self reflects what the longitudinal self would do. And indeed, it doesn't make any logical sense in the way we assess capacity to think that it takes a longitudinal perspective, because it simply doesn't. It's time and decision specific. And I think that's really highlighted in someone like Molly, who struggles to project themselves into their future. Poor concept of self into the future. I think the second thing that this tells us about capacity assessments is that they are fundamentally interpersonal. And although whether you have capacity might be thought of, at least intuitively, as being entirely sitting within you, from a medical perspective, it only makes any sense in an interpersonal fashion. You have to hear what I have to say to you about the information required to make a decision, and then I have to accept that you have weighed it in the balance and understand what you said. This is a contract between the two of us about what's going on. And if I think about Molly, of course, Molly, who has borderline personality disorder, has a fundamental failure of capacity to mentalize or understand what it means in terms of otherness interpersonally. And I think that raises questions of how we understand and trust the information that we are provided. Molly's making decisions on what we'd say are difficult circumstances interpersonally. And again, when you think about the fact that many people think borderline personality disorder is not fundamentally different from all of us, it raises the question, for me at least, about the sense of having not taking into account the interpersonal nature of what happens during a capacity assessment. And the third thing that springs to mind, and I'm really hoping someone in here can put me wrong, is that capacity assessments seem to be a real value judgment about both the information that's given, and that's the information that I as the doctor give to my patient and the information that the patient then gives back to me. And there seems to be value judgments about whether what I say to a patient is believable or trustworthy, as well as a value judgment from me about whether I believe this person is weighing something in the balance. And I think this plays out most interestingly in the empirical literature, where they've changed mental health legislation away from risk in some jurisdictions to capacity. So before, if I want to detain someone in New Zealand, I detain them by saying you've got a mental disorder and you're risky. So in some jurisdictions, they've now said that's a breach of human rights, because you can have capacity and I can still do stuff to you, right? And so they've said, instead what you have to do is you have to have a mental disorder and have a lack of capacity. And in jurisdictions that have done that, it's made no difference to how the Mental Health Act works. None at all. And the best interpretation of that is that doctors just replace riskiness with capacity. So if you don't believe me and you do something I don't suggest, then clearly you don't have capacity, is the kind of understanding, at least, about what that might mean. And that speaks to the way that this value judgment is made in both directions. And finally, of course, capacity assessment's highly cognitively biased, right? What this does is simply places weight on the capacity of someone to understand information and manipulate it in a cognitive fashion. And we really notice that in Molly, who clearly has cognitive problems as one of the core difficulties she has. And in a little bit of time, I'm going to suggest that maybe these are problems that extend beyond Molly and may affect all of us. At least that's what I wonder about when it comes to engaging in capacity assessments, particularly in high stress medical situations. So, and we've talked about this. Molly's not longitudinal in the way she sees herself. She's very in the moment. She struggles interpersonally, and that's a core part of her problem. And in fact, I see many patients who struggle interpersonally when they see a doctor in stress. She finds it difficult to believe information, and certainly I find it difficult to believe non-normative information she provides me. And she has core cognitive problems, and that's one of her key problems about how she is. And so it strikes me, at least, that if I think about Molly and her borderline personality disorder, although she may fulfill criteria from a capacity assessment, i.e. she should be making decisions, I don't think any of the underlying assumptions that seem to me to sit underneath that capacity assessment Molly fulfills. And that's a problem, right? Because if I'm respecting your capacity to make a decision, presumably I'm doing that because your capacity in some way reflects your autonomy. And maybe in a second order way, what your autonomy really is doing is reflecting who you are as a kind of a genuine person. And so somehow I'm beholden to respect that, because not to do so is a failure to respect the kind of fundamental bit of who you are as a person. So even if you're making a dumb choice, you're making your choice. And let's face it, people make dumb choices all the time, at least according to some other people. And so this is just part of the human character. But is that really the case for someone like Molly? And what can Molly tell us about each of us when we're in that kind of high stress situation, particularly that high stress situation in acute care? And so when I think about this, I guess, I quite like this quote. In the way I understand this quote, people might understand it differently, is fundamentally at the core of it, people have this narrative capacity. I mean, I don't think this is what Nietzsche was talking about when he made sort of this aphorism. That's at least how I understand it. What we do as people is we make promises to others and ourselves that stretch into the future. And I think it's particularly opposite when we think about a capacity assessment, for the very reason I've talked about. We're making promises to our future self. Our expectation of what we think will happen to our future self if we either refuse or accept whatever we're offered in a real sense. And I think more and more, as we live in a world where truth, whatever that means, is questioned, that the problem here is one of belief as well. So medicine is not certain, and most doctors, particularly doctor scientists, don't like to put things by degrees of certainty. More and more that is seen as a way of degrading trust. Yeah. So in some ways, maybe I'm better off just lying. Maybe that's more moral than saying something that's uncertain and potentially being understood as bullshit. And so if I'm talking to somebody who has difficulties in understanding or believing me, and we've seen this played out in New Zealand in very clear ways around COVID, maybe we aren't getting really capacitous decisions because people are failing in this mechanism of understanding or trust. And I certainly think that's the case for Molly. And I wonder if that's the case for all of us in high stress medical situations, about whether we fall into the belief camp, and I suspect most people in here would, or whether we fall into the disbelief camp, whether that's reaches the news because we don't want our baby to have blood that might have the COVID vaccine in it, or doesn't. And of course, no matter what kind of gymnastics we want to do, what I can't do is tell Molly what will happen in the future. I can't guarantee her a painful death if she refuses treatment. And I can't guarantee her, 12 hours of a drip, no problems at all, and see you later if she accepts it. All I can do is tell her the odds. And in fact, in much less scary ways, this is true all the time. And so trying to figure it out and trying to be able to express the vagaries and the uncertainties while still communicating the difficulties, in some ways, I think makes it more problematic or more difficult in trying to understand how things work, at least from a capacity type sense. And this is a total tangent, but one I can't get out of my mind. It is the reality that for all of us, as our emotions go up, our capacity to cognize goes down. And this is kind of how it is. We talk about this in therapy quite a lot of the time, but if you're in a high stress situation, like a medical consultation or medical emergency, the risk here is that you're not going to be engaging all of your faculties, at least your higher cognitive faculties, because your affect will overtake them. There are two books I think everybody should read. So one is called The Drunkard's Walk. Go find it and read it. It's an awesome book. I think it's changed my life more than any other book. Second book that I think has changed my life more than any other book is this book by Mark Solms. They're called The Hidden Spring. So Mark has the unusual position of being a psychoanalyst in the Lie on the Couch and Tell Me About Your Mother sense, as well as being a neuroscientist. And so what he's done in The Hidden Spring is to talk about some of how he has combined those two things to think about what it means to be a person, and what really drives what we do, our behavior. And I guess what he's trying to say in this quote here, and says in much more detail in his book, is, essentially we are driven to behave by our emotions, not by our rationality. Our rationality is the way that we retrofit what we feel so that we are comfortable with how we are. And so if I think about someone like Molly, she's going to retrofit her cognitive decisions to her affective state, which kind of has a strong explanatory power. When highly distressed and taking the paracetamol, she's still highly distressed, and so will seek support. After coming into hospital and essentially being shown kindness and care, she then becomes a lot less distressed and no longer needs the support that hospital might provide. And so now emotionally is much more likely to distrust what's going on because of her problems in her affect regulation. And so now her emotional drive is essentially to leave hospital, although she's able to articulate that to us, retrofit that, a cognitive explanation as to what she's doing. And so I think that leaves me at the point I'm at now and this problem I have. So I think when I do a capacity assessment on someone like Molly, they will always pass, but I don't think any of the assumptions that that capacity test takes into account are real. I think that some of the issues that Molly throws up for me are true for all of us to some degree, which makes me wonder if actually doing capacity tests is moral. And if in some ways what I'm doing is something for me and or the law, which in some ways might actually be harming or ignoring what a patient's real wishes might be. And I've been an SMO now for a long time, about 16 years. I'm still not sure what the best thing to do is. So if people in here can help me, I'd very much appreciate it. I'd be interested in your thoughts about this and directions I can pursue to try and put it all together in a slightly more articulate fashion.
Thank you so much, Giles. So I want to, we've got people in the room at the Bioethics Centre who I can't really see, and people online. So I can see a few hands up in the room. What I want to do first is just ask a question that came through to me on the chat from Sue Pullen, who had to leave early. So I'll put that question to you, Giles, and then we'll move to questions from the room and questions from our other Zoom participants. So here's Sue's question. She asks if it makes a difference if people like Molly have dependents, for example, children. And she thinks that that would have influenced her answer to the question of whether or not to treat Molly, and wonders whether that should matter in your view.
So from a clinical perspective, the answer is no, it doesn't make any difference. From a research perspective, understanding what people with significant personality pathology do, there's very little research that looks at how this works if they have children, but it tends not to lead to change. Having said that, some of the core characteristics, or at least the intensity of them, change over time. So people talk about people with borderline personality disorder burning out or being less intensely distressed, also changeable. I think for me, at least, when I think about the question of capacity, don't think it's particularly relevant, at least in a legal sense, because we have such an individual way of viewing capacity. It's a singular person decision. So I'm not sure it helps me when I think about what I should do.
Okay, great. Thanks very much, Giles. So I think there's a hand up in the Bioethics Centre. Is that right? Someone in there want to ask a question?
Yeah.
Is it Grant? Okay, thank you, Grant. Go ahead.
I can see you're coming from this narrative conception of the self, and of course the difficulty is, in traditional autonomy terms, about the only thing that can override it is immediate risk to life for a clinician. But I think, given that we all live and attend to narratives all the time, perhaps you are enjoining us to put a slightly greater weight as clinicians on the sense that we have that this is not going to go well unless we give the person time to draw back and think again.
Yeah, thanks, Grant. I think that's an interesting question, and essentially I agree. I've read a bunch of stuff about people who believe in the diachronic self, kind of existing in a minimalistic sense moment to moment. Intuitively, it makes very little sense to me, but I think from a pragmatic perspective, when I think about capacity, it's not logical. Because as I've said, we're not making decisions for our now self, we're making decisions for our future self. I also agree with you. I think the principle of the sanctity of life is talked about a lot. And from a knowledge perspective, you can't help the fact that doctors will have some knowing, which is hard to get across to patients, particularly in situations like this where there isn't an absolutely certain outcome. And so I think the more I think about this, the more I think the concept of narrative is important. And the other thing, which I haven't talked about because I don't know how to weave it in, is this kind of concept of trust. And I wonder at the end of the day, actually, if it's more moral, it's more right not to do capacity assessments at all, but to do some kind of trust assessment. I have no idea how you do that, but that's what I wonder about. So yeah, I think you're bang on the money. I totally agree with you, Grant, which is lucky for me.
Well,
Thanks.
thank you very much.
Thanks, Giles. Just a request, could you stop sharing your screen, and then we'll be able to see you, we'll be able to see more of you and everyone else.
I shouldn't stop sharing my screen.
Thanks very much. Okay, so we have a question from Ben, and then another question from someone in the room. Just a reminder to people on Zoom, you can use the raise hand function by clicking on the reactions tab. So if you want to ask a question, you can do that. Go ahead, Ben.
I agree with you about capacity assessment not being a useful thing to do, but part of where I'm coming from is that capacity assessments tend to only be used if there's disagreement. So whether Molly has capacity or not won't be a question if she just goes ahead with what the doctors think is the right thing. And in terms of simple stuff that I do, family thinks Mrs. Jones should go into the rest home. whether Mrs. Jones has capacity or not. If everyone agrees, then doesn't change management if you assess her capacity and decide it's not very good, because as long as she's not unconscious, that she retain. And what do we mean by partial capacity? And, how does that all fit? So it seems to me that the problem is that we're asking the wrong question, that the current paradigm has this idea that the patient has choice if they have capacity, which actually is crap, because we manipulate their choice by the information we give them. If they don't have capacity, we then have the power to make a decision for them. And it's all about who should have the power to make a decision. Whereas I think, and I think you're right on the money talking about the trust thing, I think that the issue here is that you've got a problem with disagreement. And what are your strategies to deal with disagreement? One of them is to strap her to the table and force her to have the treatment. And that may save her life. But it's not the only one. And in fact, I've had a couple of experiences where force has been applied and the net effect in a less acute manner, but the net effect is that they just then disappear from having any healthcare whatsoever, because the last time they came in, someone forced them to do something and they didn't like it. So I think the idea of actually backing up and saying, okay, we haven't got agreement, let's back up and do trust building. Not trust assessment. I think the whole idea of whakawhanaungatanga, of just sitting down with them and saying, how are you? What do you want to do? And this idea that her decision is in some way fixed. It almost certainly isn't. And as you say, she was wanting help when she was really distressed, and then when she becomes less distressed, she's changed her mind. And it may well be that she'll change her mind later again. And I guess my view would be there are very few circumstances where the exertion of power we can be sure leads to a better outcome. And Grant describes the one exception that I think is there, which is giving a blood transfusion to a Jehovah's Witness child in the middle of a theatre when no one else knows what's going on to save their lives. But I think that's such a narrow example. I think in all the other circumstances, by using power, you disrupt the relationship. And if you haven't got a relationship, there's a whole load of things that you just can't do, particularly around trusting the information that you give them.
Yeah, look, I agree with you, Ben. So much so, I've taken the government to court to give me less power. So I absolutely agree with you. And I see the comment in the chat, and I think the UN Convention on the Rights of Persons with Disabilities, which includes anybody in psychosocial distress, so has a mental disorder, are covered, essentially. They do talk about this notion of supported decision-making. So just because someone has less limited capacity to make decisions doesn't mean we shouldn't be listening to their decisions. But it remains, the thing I find interesting in reading about the UNCRPD and the stuff about it is no one talks about the underlying kind of ethics of it. No one talks about the principles of it, how we should be thinking about person. And people just talk about human rights, which arguably is ethical. But it's kind of an argument that devolves down to what does this mean? And how will people look at this in the future? So, if we end up with a much more collectivist society in 2 generations' time, people are going to think we're bananas at the current time. And so although I hear and have read a lot about that debate, I'm not sure it's that helpful informing what I do on Tuesday at 7 o'clock. And that's where the issue lies, I think.
Thanks, Giles. A question from Scott in the Bioethics Centre.
Good afternoon, Giles. Thank you for your presentation. Incredibly interesting area. Just to give you a bit of background, in a previous life, I did a fair bit of advocacy work that specifically focused on sitting with and helping people going through the court processes under the Mental Health Act understand the process so they could more fully participate in the decision making. So more of a sort of enriched consent approach. But my question today is actually more around whether or not we're potentially dealing with 2 different categories of things here. In the case of Molly, given the immediate proximity of risk, given that going back, and it's been a while since I've checked the literature on philosophy of suicidality or that digs into the idea of suicidality, the general consensus tends to be that in distinguishing it from euthanasia, any suicidality is irrational. It's just a state that can't be understood from a rational state. So then it immediately kind of fails the consent test on the understanding and weighing in case. So on that basis, I'm with Grant in the case of Molly, strap her down, go for gold. If you can't, if you don't have the time to do a more relational and compassionate trust building activity is the way that Ben has understood. But do you think that there is a different category in here if we take it away from the immediate proximity and look at more of the sort of COVID vaccination cases where the immediate risk is further ahead? Do we have two different kinds of beastie in play here?
Yeah, I mean, I think that's a fascinating question. So I've not read a lot about the philosophy of suicide, but what I can tell you anecdotally from having done this for 23 years is that an awful lot of people who hurt themselves don't do it to die. They do it to feel something, to feel nothing, to feel different. There seems to be something physiological that happens when you cut yourself, and that the internal monologue that explains why you are doing something sits orthogonally to the lethality of what you do. I mean, I've seen people who are absolutely suicidal and they've taken 4 paracetamol, and people who are absolutely not, who have taken 200. And so I mean, I think it's an interesting question, and it's not one I've really thought about. But I think more and more, and this is what I find really interesting in this space, is that I think what Molly or people with borderline personality have are a confluence of cognitive, affective, and behavioral problems that affect us all. So I think what they do is highlight the case for all of us. And that's why I find it particularly interesting. Yeah.
Thanks very much, Giles. So we've got a bit of a queue forming for questions. So we'll hear from Jasmine in the centre, then Angela and Simon. So go ahead, Jasmine.
Is there a risk for bias on the doctor's part in terms of potential legal or moral repercussions, which make them believe their opinion is more sound than the patient's? Does it make you feel guilty when you respect a patient's opinion, which might differ from your own?
Yes, is the answer to that question. We're worried we'll be sued and struck off. Yep. So that asymmetry absolutely exists. I mean, I don't think it's moral, but it's certainly, I think it's immoral actually, but it's certainly legal. If you take someone like Molly, for example, if I admit her to hospital or strap her down and treat her, I have no risk of consequence in a very practical sense. If Molly goes and Molly dies and Molly's dad happens to be the Prime Minister, I'm going to be looking for a new job in a week. And I'm certain that plays on people's minds, health professionals' minds. I don't think it should, but it does.
Angela, go ahead.
Thanks, Giles. So 2 questions. Well, one's a question, one's sort of a suggestion. So Hilary had put this idea in the chat around the UN Convention of the Rights of Persons with Disabilities, and you'd said that you hadn't found it necessarily that helpful in terms of it applying to the specific kind of discussion around trust that you were looking at. But I mean, my interpretation of supported decision making is the idea that capacity doesn't sort of exist in a vacuum, right? And that someone might have capacity in one clinical scenario if they're getting more support, and actually might legitimately be assessed not to have capacity in a different scenario, different hospital, if they're getting less support. So I think kind of, to me, it does seem to speak to your suggestion and Ben's suggestion that actually if we invest in relationship and we invest in building trust, we can get someone who might be just kind of under, taking that as it is, under that line of capacity up to being at the point where they can make a decision for themselves. So I thought perhaps it's more useful. And my other comment was just to ask why, I'm interested in why you describe Molly as attractive. Because there's lots of work around kind of epistemic bias in terms of who we think of as having credibility and authority in language and discourse, and what you're trying to assess is whether, to what extent she retains information and is a credible decision maker. And we know on the grounds of kind of race and certainly weight that impacts our assessment of people's epistemic credibility. So why did you describe her as attractive?
I'm going to start with the second question and then answer the first one. I describe her as attractive because I'm trying to do my living best to make people strap her down, to see that there are problems, because somehow saving someone who's attractive seems more relevant than not. But no one apart from Grant found her attractive enough to strap down. So it didn't work, basically. I do want to go see the whale. But it actually reflects clinical reality. So often many people who are emotionally dysregulated and self-harm fulfill a stereotypical attractive role. And, you know, as psychiatrists, we spend loads of time in therapy and talking to each other and peer review, but none of my other colleagues do, and they all think we're a bit nuts for doing it. And it's interesting watching how those interactions are different according to the patients they see. And it is really clear in some areas. So, you know, we detain 4 times more Māori than non-Māori. I mean, it's just got to be colonial. It's systemic racism. It's not anything else. But so that was the reason for describing her as attractive, to try and generate a little bit of grist. But you're all in far too much of a lefty bubble to get me to do that. It works brilliantly when I do this sort of thing with ED doctors. In terms of the issue around supported decision making, I think one of the problems is that there's a vast amount of literature and no translation. So lots of people write about will and preferences. You know, it's just the same as weighing stuff in the balance. Lots of people write about support, but if you boil that down, what that really is looking for is to support someone's legal capacity as opposed to their medical capacity. And actually, there is no evidence of any sort it works, which might change soon because we've got an HRC grant to actually try and see how this might practically roll out. And there are difficulties about the time and a pressured healthcare system. So I think it looks fantastic, just doesn't work on Tuesday at 7 o'clock in the ED room. Yeah, yet.
Thanks, Giles. Simon.
Thank you very much, Giles. I just want to work out what's happening with the argument. So you've given us a lot of reasons to be doubtful about the model of capacity assessment that's being used and the way that works in practice. But you raised the question, so should we compulsorily treat this patient or any other patient in a comparable situation? And then you told us about borderline personality disorder and gave us reasons why we might, it seemed to me, this is what you're saying, question whether she is in fact making an autonomous decision. You've made a number of points about the nature of what you think autonomy is, so particularly that issue about decision-making being forward-looking, and you emphasize the stability of values. So it sounds to me like your position is actually, we do still have a need for compulsory treatment, granted all the reason to be very hesitant about that and the ways that it could be harmful and destructive and counterproductive, etc. There still may be a space for it, and the reasons would have something to do with the analysis of borderline personality disorder that you've put forward. Which I think actually sounds credible, because I think it pushed on the point. I was being hesitant. I do think we should be compulsorily treating some people in some situations, all other things being taken into account. So, am I right in terms of what you're arguing?
You know what I think, Simon, when it comes to so the conflict of interest, I do some work with Simon, I really like him, and when it comes to arguing, he's always right. So of course you're right. But I think you are right. So, you know, I spent a long time thinking about the fact I hate having the capacity the ability and maybe the expectation to detain people. And I spent a lot of time thinking, working a variety of ways to reduce that power. But I think Molly raises some interesting problems about this combination of difficulties you come up with in Molly, but also more generally in people. I mean, I don't know how many people here have been in an emergency room stressed, but I've been there before, both by myself and with my kids, and I don't make any decisions. I don't want you to sit down and hold my hand and talk to me for however. I want you to fix the problem. And I guess because of who I am, I just trust you're going to do your best. And so that is the key issue here. The tricky, I mean, the trickiness here, and I can see Hillary's dropped something else into the chat, and I agree with all of this. You know, I think forcing treatment on people feels intuitively wrong to me. But
yeah,
kind of leaving someone
but equally leaving somebody, yeah, exactly. And
balancing that up is incredibly challenging.
Yeah. Okay, thanks.
Thanks very much, Giles. We've got one more question in the room, and then we'll get to Jim and Mitch. So go ahead, the question in the room.
Hi, my name's Charlie. I'm a psychiatrist, and I work at Ashburn Clinic with some of the most trust poor, personality disturbed, and otherwise complicated patients in the country. And the capacity assessment is just from for me, if you put it through the paces, a test for verbal language skills, where the higher the attainment, intellectual attainment or scholarly attainment of the patient, the easier it is for them to argue, whatever. But sort of what we do sneakily is sort of try and construct a narrative identity and do a genuineness test in this person and my experience of them, and preferably a whole team of people, because the thing about personality disorders is they have, people with that disorder have a gift of making the people interviewing them feel lots of things, which makes it sometimes very difficult to, very tempting to think you have objectivity, which you most definitely do not. So we do a long team of people and say, in the 90% of this time that this person is relatively consistent, would they do this? And that's how we sort of test those decisions, that they need to be tested, but that I'm aware that that is incredibly expensive and requires a relationship. And yeah, for us, sometimes 6 months to a year of trust building before we can even do that reasonably. So that would never translate to an ED.
And I presume that's you, Charlie. Hi, I can't see anything on this. It's I don't know, you'd moved to the Ashburn Clinic. And I think you highlight the problem beautifully. In that trust is a problem for all of us. And what Molly shows us is the extreme version of that requires a year of inpatient work, which, you know, maybe I think 8 New Zealanders get a year. And so there is a real practical consequence to this, as well as there being, I think, a need to have a bioethical understanding of how and why we're doing what we're doing. It's and that is the crux of the problem.
Thanks so much, Giles. I think we have time for perhaps just one more question or two if they're very quick. So go ahead, Jim. If you could just unmute Jim, please, so we can hear you.
My apologies. This is an observation more than a question. Some years ago, I was approached by the Jehovah's Witnesses in Dunedin Hospital. I ran the blood transfusion service, and they were bowling up to explain to me how they operated. And I said, yes, I understand that. And yes, you do not need transfusion for almost all surgery if you take additional steps. And I'm prepared to support you in that. So here was me, the transfusionist, supporting the Jehovah's Witnesses people. What did that lead to? It led to a sense of real trust between us, and it led to policies and protocols being established in Dunedin and then extended out right across New Zealand and to Australia as well. So I think in the group behaviour sense, you can actually make progress, but it needs to be offline. The hot activity that Giles has described, however, I think still requires a need to spend some time to try and grow trust before questions are framed, and whether in fact the treatment can be modified or handled in a different way.
Thanks, Jim. Mitch, go ahead, final question.
Thank you for your talk. With the case of like the archetypal case of Molly, I'm spending a fair amount of time in like a Midwestern emergency room. The case, some of those cases seem to be confounded by like pre-arrival like pharmaceutical interventions. It was common that some patients coming in similar to Molly, they'd get like IM midazolam or olanzapine, and it seems like that some of these interventions could potentially muddy the assessment of the capacity. I don't know here in New Zealand, does that happen to be the case ever? And do you think some of those interventions are significant when like assessing capacity?
Look, I think the short answer is yes. If you give someone that changes the way their brain works, then arguably their brain isn't working in a way that speaks to their narrative will and preference. I think one of the interesting things about someone like Molly is I think just being in the ED room does the same thing. But it is true, you know. and certainly when people come in and they're drunk or they're high, we would just do what we'd consider our duty of care, which is the flip side of this coin that we haven't talked about, is if we don't think someone's got capacity, what do we do? Well, what we actually do is make a normative choice about what they think they need and then do that. So, you know, if we thought Molly was drunk or had olanzapine on board, or, you know, had taken a benzo, so something that would impair her consciousness, we'd do the normative thing. And we'd make the presumption that's what Molly wants. And I guess that's the difficulty, and the flip side of this coin is how that plays out. Or what that tells us, I guess.
Thanks so much, Giles. We've really maxed out our time, and we really appreciate your time and your contribution to the seminar. So thank you very much, and thanks to everyone for joining us today. Just to let everybody know, we have a presentation next week from Grant Gillette entitled Rhythms of Life, Brain Damage and the Recovery of a Self. So that's at the same time next week. So thank you, Giles, and thanks to everyone for coming.
Thank you very much. Really appreciate it.